Wow, the view here is incredible. So many people. Your Excellency, Dr. Carolina Darius and Sebastian, Professor Kathy Pritchard-Jones, SIOP President and the Board of Directors, dear friends and colleagues. Last week, I was looking at my old diary and I saw the below entry. In July 1999, our son Rakan's leukemia had returned despite going through a horrendous 2-year aggressive treatment protocol. As you can imagine, this was a severe blow, and once again, we as parents were thrown into the scary unknown. Bone marrow transplant was now our only chance for a cure. Fortunately, Shireen, our 4-year-old daughter then, proved to be a good enough match for her brother. Of course, we were very relieved. But up until the doctor said that we needed to have her approval. And that was not it. Apparently, as per the rights of the child, the psychotherapist will explain to Shireen intricately the details of the bone marrow donation procedure, including how they will insert a huge needle in her back and scoop something out of it. As you can imagine, we were horrified. How will a 4-year-old who typically had to be bribed just to have her normal childhood vaccinations give her approval to a procedure that involved a lot more? We were terrified that she would say no. They said, leave it to us. Off she entered into a room with a psychotherapist, and out she came after a good 15 minutes. That felt like a lifetime. She came out bursting with excitement. Mama, I am part of the team. Me, you, Baba, doctors, nurses, grandma, grandpapa, we will all help baby Rakan. We were astounded that a mere 4-year-old understood the value of the team in supporting a cancer patient. And that is why I am beyond honored to be the first patron for SIOP. The SIOP community not only understands the value of the team, it is firmly embedded in their DNA. This is of the few congresses that I have been to, and I have been to many, trust me, that includes everyone. It includes oncologists, nurses, surgeons, psychiatrists, scientists, parents, and survivors, all under one roof. This meeting of minds and hearts today, face-to-face this time, is so crucial, as we still have a monumental task ahead of us all, especially after COVID. As we speak today, great advances have taken place. Treatments for the most common childhood cancers have improved and cure rates have risen. But the thorny question remains: for whom? Access to care, even for the most common cancers, is still for the privileged few. A mother of a child with cancer in a low-middle-income country in 2022 will still be told the magic potion that will save your child is available. But so sorry, it's not for you. This is what lack of access to treatment is all about. We can sugarcoat it all we want, but it is about the harsh and tragic reality of depriving a human being from a life-saving treatment. The good news, however, is that finally childhood cancers have entered global advocacy. The WHO Initiative for Childhood Cancers, GICC, promises to change this deadly narrative. What is special about this initiative is that it is forging and facilitating a more formal, efficient, and impactful technical, collaborative infrastructure, and architecture on a regional and global scale. And this is where SIOP, as a key partner of this initiative, has a big part to play. With its 3,000 members across the whole world, and with its already organized regional infrastructure, SIOP's convening role is well placed to disseminate knowledge and innovate across its membership fast. In addition, SIOP's training and education focus that has been its flagship program is crucial for helping to fast-track increasing capacity in low and middle-income countries. What's more, SIOP's program for advancing the research capacity, PARC, for pediatric cancer clinical trials in low and middle-income countries will help enhance the capacity for research-informed treatment to improve the care and cure for children with cancer. Research capabilities cannot only be a monopoly for the rich countries. The GICC's initiative offering of an organized technical support on a global scale is fantastic, especially in view of the monumental task of having to increase the capacity of services and oncology healthcare staffing in low middle-income countries. I have been to some countries in Africa which boasted one oncologist for a population of 20 million. So to say the least, this support is urgently needed. But if we are to meet the target of the GICC initiative by 2030 that promises to save 1 million more children, we all need to acknowledge that we cannot keep doing the same thing and expect different results. By all, I mean governments, oncology health workers, donors, pharma, supply chain, distributors, advocates, and the global health community. Everyone in the system. After all, as quoted by Professor Mukherjee, medicine is no longer delivered by a doctor with a black bag. It is the healthcare system that delivers. I would like to share with you some of my humble thoughts on how we can all play a part in achieving our goal. Technical expertise is extremely important. However, one can have all the technical expertise in the world and even the money to deliver cancer care, but that is not sufficient on its own to change the narrative for cancer care. And that was our story at the King Hussein Cancer Center in Jordan, KHCC. We had the building, the latest machinery, the health workers, and yet until 2002, we were not able to deliver quality cancer care to our people. It was only when we fixed our governance, managerial structure, that we were able to uplift our King Hussein Cancer Center to what it is today. As president of UICC from 2018 to 2020, I also saw firsthand the detrimental effects of the lack of governance, planning, and managerial expertise all over low and middle income countries. I am glad to know that GICC is supporting ministries on how to strategize and forge achievable cancer control plans. The right governance and managerial architecture must be implemented at city and national levels. The City Cancer Challenge initiative launched by UICC understood this. City cancer executive teams were forged that included all stakeholders, including oncology doctors, technicians, nurses, patients, champions, the mayor, and the private sector, everyone, all sitting on one table, and most importantly, working on one national plan. You might think that this is what the logical thing, this is what must be happening, but you will be surprised. In Paraguay, I met with the newly formed City Cancer Challenge team and asked them when was the last time they spoke to each other. Not one single person put their hand up. So the architecture, the managerial architecture on the ground is key. Quite often, even well-intentioned NGOs can exacerbate duplication and disjointedness of support when working separately with different entities. However, by having a representative, official reference point, such as an executive team in a city, it becomes the receptacle of all the support and therefore has the potential to become an amazing local engine that can deliver the complex long-term solutions for cancer care based on one plan. SIOP members, you as members represent thousands of organizations in your home countries. We need you to advocate more strategically and more deeply. Lobby your governments to exercise strong political will, without which nothing can happen. I think we should duplicate the minister here, Dr. Carolina, and duplicate your person all over low middle income countries, because surely we can see in Spain strong political will. Another great example is the partnership between the Rwandan government and Partners in Health, and we've seen the progress in Rwanda specifically because of the strong political will exhibited there. Lobby your hospitals and centers to twin with other hospitals or centers in low middle income countries. Again, our story with the King Hussein Cancer Center is a testament as to what can be achieved what was achieved in pediatric cancer care in Jordan. St. Jude's Children's Research Hospital committed long-term partnership with us. It was crucial. St. Jude shared their governance expertise, offered fellowships to our doctors, joined with regular training of our nurses, held monthly online joint second opinion sessions, and even shared their fundraising secrets with us, and still do to this day. Sick Children's Hospital in Canada was instrumental in developing and upgrading our brain tumor department. Princess Margaret Hospital in Toronto receiving KHCC fellows year after year for radiotherapy. This kind of real, committed, long-term partnerships are beyond impactful and truly change the narrative on the ground. Join well-organized, on-the-ground initiatives such as the City Cancer Challenge models in cities. Imagine if you all target your multidisciplinary technical support to these well-organized focal city plans. The impact would be bigger and it would be faster. And one last point I want to share. I know that we all strive to strengthen the health system in countries. Of course, this is the ultimate sustainable goal. But from my humble experience in Jordan, sometimes it is easier to start small and focus on the one cancer center of excellence as a model, as opposed to trying a whole health system with all its multi-year baggage and inefficiencies. I feel that sometimes we all struggle with pulling the cart before the horse syndrome. In our case in Jordan, fixing our health system with years and years of baggage proved to be hard. The idea of fixing one center that can become the horse in moving cancer care forward proved successful. Now KHCC is taking a leading role in training Ministry of Health workers in oncology. KHCC is about to manage a whole cancer department in one big governmental hospital, with the potential to open satellite centers in the north and the south of the country. The success of KHCC helped reverse the brain drain. There is not one model that fits all. I believe that it is time for governments and the global health community to take the lead and decide what is the best model for them, given capacity and finances. Sometimes betting on the horse will get you there faster. As to financing, global health funding must step up. Cancer fight requires a war chest. The UN's Health for Life Fund is a welcome new initiative. But having said that, governments should also realize that financing can also come from local sources as well. Funds can be released simply from reducing inefficiencies of local health systems, but more significantly from investing in the prevention and early detection of NCDs. By implementing evidence-based measures that include taxing the industries that harm our health, governments can make people healthier, reduce cancer and NCDs by 30%, protect women and children, and even put money in their coffers for COVID-19 response vaccines and recovery efforts. Amazing. An amazing formula. More should take it up. The Philippines is one such example. They targeted their tobacco tax, cleverly calling it the anti-cancer tax, towards universal health coverage for cancer for people with challenged resources. It can be done. Changing the cancer gap between the North and South can be done, my friends, when we tackle all the nuts and bolts in the system. It is time for a new leap forward in childhood cancer care, and it is time to double our efforts for fighting for childhood cancer care for all God's children. Thank you very much.